Okay, as the clock ticks across to 4 o'clock, I shall say hello to everybody. Welcome. It's lovely to have you here at Curtin Corner, and welcome. For those of you who don't know me, my name is John Fullermore. I'm the Director of the John Curtin Institute of Public Policy, or JCIPP, here at Curtin Corner at Curtin University. And if you've never attended a Curtin Corner before, it's great to have you here. And of course, for those of you who've been before, welcome back. And I'd like to begin by acknowledging the Whadjuk people of the Noongar Nation as the traditional owners of the lands from which we are hosting today's webinar, and wherever you're watching from on your behalf. I, of course, would like to pay my respects to traditional owners and their elders past and present. And for those of you who've never been here before, you may not know, but we've been running Curtin Corners on a Friday afternoon now for around 20 years. Speakers from inside and outside the university on a range of topics connected to politics and public policy broadly defined. We record the session and we put them up on our website later on, along with the slides. So please take the time to look at some of our past talks and encourage your colleagues to do the same. It takes a few days, but not too long, for the talks to go up on our JCIPP website. And all the ones we've held this year so far are already up. And this one will be up here, hopefully on the website by the end of next week. And we've got recordings from the past at least 5 years and possibly even longer. So if you would like to look at some of those talks from previous years, just browse your way through, and I'm sure you'll find some very interesting presentations there. We also like to encourage debate. So later on, we will invite you to ask questions of our speaker, and we use Slido. That's Slido. It's very easy. You just go to your browser and type in the word Slido, or you can go to www.slido.com. And you have to then enter an event code, and our event code is JCIPP. And you do that, and then suddenly you can ask questions, you can like somebody else's questions, and I'll then facilitate the Q&A with Sarah at the end of her prepared remarks. I've always found it easiest to ask the questions and look at Slido on your mobile phone, and you can watch the presentation on your computer at the same time. So I'd now like to introduce today's speaker, Sarah Cowie. Sarah is the Director of the Health and Disability Services Complaints Office, or HaDSCO, a position she's held since 2016, so 10 years. Congratulations. In her presentation, she's going to explain in some detail the important work that HaDSCO does. She's been involved, Sarah has, for more than 40 years. She says in complaint resolution, integrity, oversight, and before she joined HaDSCO, she was an assistant ombudsman in the WA Ombudsman's office. She's been engaged in a range of service delivery and policy roles, and she's worked on strategic initiatives at the state, national and international levels. And I noticed actually from looking at her LinkedIn site, I think that she's worked to strengthen ombudsman services in Indonesia, for example. She's a board member of the Society of Consumer Affairs Professionals, the leading organisation for complaint handling professionals in Australia. She's a graduate of the Australian Institute of Company Directors, and she's got a BA from UWA. So Sarah is very well qualified and has a lot of experience to talk about this really important issue. And I'm very grateful to her for agreeing to give tonight's Curtin Corner presentation. So Sarah, we're all looking forward to it. Over to you, and then I'll come back later on and do the Q&A. So thanks very much.
Thank you, John, and it's a delight and pleasure to be able to give my presentation to everybody today, The Positive Power of Complaining, How Feedback Can Change the Health Sector. I'm going to divide the presentation into 3 parts, one to tell you about our role, give you some case studies, and then bring everything together to show how the power of complaining can actually improve quality and safety in health and also patient-centred care. So first off, I would like to acknowledge the traditional custodians of the lands and waters throughout Western Australia where our services are accessed. So our reach is through the whole of Western Australia. So just a little bit about ourselves. We're an independent statutory authority with 26 staff. Not all those staff are complaint handlers. Some are involved in outreach and some are involved in business services. But we are established under legislation, the Health and Disability Services Complaints Act 1995. This office opened in 1996, was called formerly the Office of Health Review. I report through to the Minister for Health for mental health. We provide a complaints resolution service, an impartial service across health, disability, non-NDIS providers, that is, and mental health services in Western Australia and also across into the Indian Ocean territories. Our reach is very broad. We cover the public, private and not-for-profit sectors and also prison health services. We do have an interface with the Australian Health Practitioner Regulation Agency that deals with registered practitioners. There are 16 practitioner groups that are managed by 15 boards through AHPRA, and I'll tell you a bit more about that as we go through the presentation. We also manage complaints about unregistered health practitioners. So whereas AHPRA will deal with the registered ones, we deal with the unregistered ones under what's called a statutory code of conduct for healthcare workers. I'll tell you more about that because that's a very interesting and fairly recent jurisdiction. And we also manage complaints under voluntary assisted dying legislation. I was actually talking with two of my staff today about a current matter we have before us under that legislation. In some ways, a good way to think about what we do is we're similar to what might be considered to be a health ombudsman. Offices like ours are across all states and territories in Australia, and in Queensland, the position is actually called Health Ombudsman. So what drives our work? We really do believe that there should be access to safe and ethical healthcare for individuals and for everybody to be treated with respect. They are key drivers for our work. And we really do focus on improvement in the delivery of health services through complaint resolution. Because what our work is done within a confidentiality framework, not many people actually get to know the outcomes and how we influence health. So this is a great opportunity to tell you about that today. And I say at this point, though, that not all matters that we say demonstrate that there's been poor service delivery. Sometimes it is a perception of individuals. And in general, I would say that we have a really good health system in Australia and in Western Australia. We just get to see things when they don't quite go the way they should. Now, you may not know, but there actually is an Australian standard about what is a complaint. And this actually drives the work that we do, as well as the powers and the definitions under our legislation. But basically, it is this expression of dissatisfaction made to or about an organisation relating to its products, its services, its staff, or the actual handling of a complaint, where a resolution is explicitly or implicitly expected or legally required. So in terms of who can bring a complaint to our office, it has to be the person who's received the service, or it can be a representative. It can be a family or a carer. It can also be an advocate. So people like the Mental Health Advocacy Service or the Health Consumers Council can represent people in complaints to us. A complaint can be made by a representative of a person who died, and that's a fairly common type of complaint post-death. And that can be quite emotionally challenging for staff, as well as can be re-traumatising for the individuals who bring the complaint. And then a carer in their own capacity under the Carers Charter can actually bring a complaint. For example, if they feel they haven't been involved appropriately in decision-making for the people that they're caring for in a health setting. But under the Code of Conduct for certain healthcare workers, which is all about unregistered practitioners, anybody can make a complaint. And in fact, we can be referred matters and can initiate investigations on our own behalf. They're called director-initiated investigations. And we have a good relationship with WA Police, and they send us matters where people are enter into custody. An example would be a massage therapist who has essentially been involved with sexual assault of their client. So there are so many types of complaints that can be made, and it is just so vast. Basically, and this picture is just there to show you the vastness of it, but it is huge. It covers ambulance service, it covers hospitals, general practitioners, nurses, doctors, psychologists, psychiatrists, community practices, community mental health, and the list just goes on. But basically what we say is anything is a health service until it's challenged that it's not a health service. And health services are defined under our legislation. But the message is that it basically covers everything. There are actually some complaint thresholds, though, about bringing matters to our office. First off, it does have to be about a health or mental health or disability service. And then it must be about a service that's provided within the last 2 years. Sometimes we do have matters brought to us that are over 10 years old, or they might be, people get concerned, anniversaries of death, people might bring a complaint 5 years later, but people have moved on, systems have changed, records have changed. We do find that that 2-year threshold can be met, but there is discretion if someone brings a complaint outside of that time, if they can justify why it should be dealt with. We don't actually, though, deal with the matters where there's been a determination by a court or a tribunal or a registration board. And then we must actually stop dealing with a matter if we know it is proceeding to court or it's before the state administrative tribunal. An example would be where people are seeking compensation. That's got very legal boundaries around it, causation, etc. We are not an alternative to a court, and so matters that are going to court for compensation need to be in that system. We can deal with goodwill payments, acts of grace payments, but they are basically because an individual health service provider has decided to pursue that course of action through our complaints process. Now, our staff, it's very important that they're impartial. We actually all have to take an oath of confidentiality, oath of office, or affirmation of office when we join, and that's a requirement. And I hear all those oaths as people join our office, and they are bound by that, and that's where the confidentiality comes from. It's important that people remain impartial. It's important for us in recruitment. We are not advocates, and we also are not apologists for service providers. We need to sit right in the middle. If we move to become advocates, we are compromising the independent process. Likewise, if we move to be on the side of the provider, we are also compromising our position. It's very important, though, in our process that matters are handled with empathy and courtesy, and we have to make our service accessible. There are some cases, particularly mental health cases, and we don't want to re-traumatise an individual who brings their complaint. So we will suggest at times that they contact an advocacy service to represent them in their complaint to us. We need to make sure our complaint service is accessible. We do have to receive complaints in writing to act on them, and that's a legislative requirement, but we can actually assist an individual to do that. And as long as they give us some authorisation that it is a correct understanding of their complaint. We do need to recognise the diversity of our consumers and their unique circumstances, but ultimately what we're trying to do is to achieve quality outcomes, redress for the individual where warranted, and service improvements for others for the future. So this shows you a little bit about our process. The key parts to note here is that we do take an informal approach to managing complaints. Our focus is to resolve them as informally as possible and in the most timely and efficient way. Now, negotiated settlement and conciliation are voluntary processes. So if somebody brings a complaint to us and the service provider, the health provider, the mental health provider does not want to engage, we cannot compel them to do that. That is different, though, in investigation where it's more formal and there are compulsion powers. So negotiated settlement is pretty much a paper-based approach. It used to be years ago when I was first in complaint handling, matters were dealt with them by letters, but nowadays it's by email and phone calls. And we look to seek resolution as informally as possible. And these matters are actually probably for the less serious matters that we deal with. Conciliation is very powerful. What we do there is we bring the parties together, so we are at the middle of the table, and try to conciliate an outcome. The conciliation is a very good tool for mental health cases, and it's also a very good tool for where there's been death. And I was reflecting today, preparing for this presentation with one of my colleagues here, how a conciliation that she led It was all about, it was a very sad situation. It was death by suicide of somebody's son in their 20s within 24 hours of discharge from the hospital. And the family could not understand why the individual had been released. So at conciliation, the parties were brought together. There was explanations given about how the process had, the clinical process involved. And at that table, everybody was with tears. The psychiatrist was with tears. The nurse was with tears. The family were with tears. And I think, conciliation is powerful in those cases because it really does show nobody's gone to work on a particular day for harm to be the outcome to the individual. And the psychiatrist actually attended the funeral of that individual. So that's just a really good example of how bringing parties together, particularly where there's been a bit of time for grief to settle, can be a really good tool. And people say it helps, the feedback we get is that it helps people to move on. As I said, investigation is more formal. We actually do have powers of entry. We've never had to use them. But we often use investigation for where there's a bit more system-wide. It might be a hospital-based situation as opposed to an individual practitioner. And we use it for our unregistered practitioner space, which I'll talk about shortly. Now, I've mentioned AHPRA and this interface that we have. So all registered practitioners, they are registered through the Health Practitioner Regulation National Law Act, which applies across Australia. And we are bound under that legislation to consult with AHPRA where a complaint names a registered practitioner. And during that consultation process, it will be determined who's going to deal with the matter. So if there are serious boundary violations, adverse outcomes caused as a result of a practitioner's care and treatment, those matters are going to sit with AHPRA. Likewise, they will send us matters through that consultation process where they believe alternative dispute resolution processes like negotiated settlement or conciliation might achieve the best outcome. So we make sure that whoever lodges the complaint or as it is a notification to AHPRA that it ends up at the right place. And it's a very good working relationship we have here with our AHPRA office in Western Australia. So you might be wondering how many complaints we received. So 3,257 is what we received in 24-25. We're expecting to receive probably 3,800 this year. We have had a 20% increase, and that builds on a 13% increase from the year before. The distribution you will see there is health and mental health. 72% health and 22% mental health. Mental health proportionally is a growing area of complaint. And even in the health space, some people present for health issues, but do have some very underlying mental health issues. The disability jurisdiction has reduced because early in the 2020s, the NDIS, Quality and Safeguards Commission, took up jurisdiction for NDIS complaints. OIJ is matters out of jurisdiction. An example there would be sometimes we have an interface with aged care, and if it's health in an aged care setting, that's more likely to be us. But if it's other issues associated with aged care, that would belong at the Aged Care Quality and Safety Commission. So with the consent of the individual, we refer either the whole complaint or a component of the complaint onto that body. You will see that as a complaints organisation and in the complaints framework that exists across Australia, we all interrelate and we all make sure the individual's complaint gets to the right place. Now, the distribution of complaints and of mental health and health complaints is shown there. You will see that it's reasonably up and down, but since 2020, there's been around about a 20% increase in health complaints and around a 29% increase in mental health complaints. The figures are there already for 25-26 to a few days ago. So as I say, we're expecting to get close to 3,800 complaints this year. Now, sometimes when I meet with the Minister for Health, she's sort of concerned that, we're getting so many complaints. But I say to her, look, Minister, it's a good thing that people lodge complaints. It shows that the system's working well, and it is a way to get system improvements. So by provider types for health, hospitals generate the greatest proportion of complaints, as you'll see there, then followed by medical practices. And you'll see that corrective services is 17% of our health complaints. So it is a fairly substantial part of that health jurisdiction. We do go out to prisons to let people know about our services. There's a telephone line. We're one of a few bodies on a free telephone line that prisoners can ring. They are not recorded, those phone calls, and also confidential mail process is used. It is an offence to open confidential mail to a complaint body such as us for censoring purposes. Dental services are down there. Often dental services are associated with costs, which is probably not unsurprising. The type of issues we get, so quality of clinical care, which is that top line, is always the highest area of complaint. Now, there are many complaint categories in there, subcategories, and they cover things like inadequate treatment, they cover discharge and transfer, which is a very big area of complaint, infection control, inadequate treatment or therapy, medication issues, pain issues, test results not being followed up, post-surgery complications. These complaint categories are the same that are used in WA Health, so we can do comparative sharing of data that show that, and their data shows the same thing, that quality of clinical care is always the highest category. They're followed then by communication, access, and costs, and they sit there. They move around a bit as to what is higher for each year, but they're reasonably similar. Communication, as you'll learn through my presentation, is a really big issue in dealing with health. I mean, when we all enter the health system, we can be nervous, it can be traumatizing, and we really want to have a good communication from those who treat us. Access is an issue. Access is the biggest area of complaint, is access for after quality of clinical care for prisoners, because being able to access health services in prison can be an issue for prisoners, and we hear those sorts of complaints. Access to methadone programs, for example. And then cost. Cost is usually associated with the private sector, private hospitals. Can be issues where, and you may or may not know this, but certain hospital costs are covered through your stay, but if then diagnostic tests are required, they are separate sometimes to hospital stays, and so what you thought you were going to pay for your service is actually higher because you've got some diagnostic testing, and that all comes through in those cost complaints. Mental health services. This is interesting because where hospitals were the highest for the service type for health, psychiatry is the highest for mental health services. And each year I do some training to some trainee psychiatrists, and I normally say, before I put up this slide, what do you think attracts the highest number of complaints? And they actually are just amazed when I show it to them, but it is the biggest area. What we find is individuals do get concerned when their psychiatrist changes, or they have to move interstate and they have to start up with a new psychiatrist. That relationship that happens between a patient and psychiatrist in a mental health space is very important. And then for second, third, and fourth place, all around similar numbers are inpatient services, emergency and A&E, and community mental health. So then when we look at the complaint issues, again, quality of clinical care is up there, but you'll see it does sort of fluctuate a bit more than the health complaints. And rights, respect, and dignity actually comes in here, because people are very concerned about privacy and confidentiality in the mental health space. They're very concerned about what goes in their records. And interestingly, for quality of clinical care, medication is always a higher complaint category than it is for health, because people either want access to medication that they can't access, or they get concerns when their medication is changed. Okay, so if I can now just move on from that, I know there's a lot to take in, but I'd like to just now talk to you about our code of conduct for certain healthcare workers. So this is a statutory code, and it sets minimum standards of practice for healthcare workers. It was implemented in 2023, and it delivered a state government election commitment and a decision of the former COAC Health Council. And myself and a few of my colleagues here were heavily involved in the development of this policy and taking the legislation through the Parliament. It was an amazing experience to be able to see policy become law. So this code has 17 clauses. It's all about protecting public health and safety, and it closes a regulatory gap to deal with unregistered practitioners, because AHPRA deals with the registered practitioners where there are serious issues, they can lose their registration. But this unregistered space, there hasn't been in Western Australia until 2023 the protections that we now have. There's 17 clauses, and they basically set out how an individual must carry out their practice. And so what can happen after investigation is that we can actually, I can issue prohibition orders where the healthcare workers' practice represents a serious risk to public health and safety. Now, if we issue those prohibition orders, they actually apply across Australia. They're binding and they're enduring. But we won't do that unless I'm satisfied by the work undertaken in the investigation that the evidence shows that the individual poses a serious risk to public health and safety. And there is a review to the State Administrative Tribunal for that individual for procedural fairness. We can also publish public health warning statements. And in the last 2 years, I have issued 7 prohibition orders. The most recent one was to a phlebotomist. Now, that's a person who takes your blood when you go for a blood test. And in this occasion, the doctor had required certain bloods to be taken of their pregnant patient, but the phlebotomist decided to take vaginal swabs instead. I mean, essentially, it was sexual misconduct. It was a matter referred to us by the police. That person is now in prison too. And often those prohibition orders apply to massage therapists. So who's covered, you're probably wondering, and it is unlimited, and it was deliberate not to actually put the types of healthcare workers in the legislation, because no sooner do you do that, then there will be another type of healthcare worker that emerges in a profession. So there's a list there, and it's just in alphabetical order, but it is only a small selection of what is covered. So audiologists, counsellors, people might be surprised that counsellors, and also social workers, they might be qualified through a degree that they've obtained from a university, and they might be protected and belong to an association that has its code. But if they do something that's not appropriate, they don't abide by the clauses, there was no power previously to deal with them. So now these code of conduct powers allow action to be taken. Doulas, that can be a challenging area, because sometimes they are midwives who've lost their registration. They know how to deliver babies, but they've lost their registration for a particular reason. They move into the free birthing movement, and there are some quite serious consequences that can happen. Now, this is taken from the 17 clauses, but the key ones here, and there's a lot on this page, I just want to highlight essentially the first one about healthcare workers must provide services and safe and ethical health services. And that is often the clause that we are looking at most when individuals bring their complaints or the police refer matters to us. And the other one at the very bottom of what you can't do is have an inappropriate relationship. And that covers all those sexual misconduct matters that I've been talking about. The other one to take note of is the second from the top about what you can't do. is make false claims to cure serious illnesses such as cancer. So sometimes naturopaths might do that, or other unregistered practitioners. I'd also now like to tell you a bit about our voluntary assisted dying jurisdiction. This was part of the state government's signature first term policy to introduce significant end of life reforms. We do provide a complaints function as part of the regulatory framework for voluntary assisted dying, and we can receive referrals from the Voluntary Assisted Dying Board. And I was very fortunate, again, like the Code of Conduct, to be involved in the development of this legislation. We were consulted about how the complaints process would work. I got to know a lot about this process, which is highly regulated. Our investigations do focus on ensuring the VAT procedures are performed in accordance with the legal and legislative framework, and then we can make recommendations, as we have, based on investigation outcomes for change. And we report to the Voluntary Assisted Dying Board about the outcomes of our investigations, and we made a submission as part of the review of the Voluntary Assisted Dying Act. Okay. So in my time, John mentioned I've been here for 10 years, and there are 8 themes that I've always seen in complaints. That first one being quality of clinical care, which I talked about. But I have to say a number of the themes, they actually belong to not just one, they often are there's more than one theme in each complaint. Quality of clinical care and communication are often there, and so are documentation and record keeping. But I might give you an example of a quality of clinical care case, and it involved an involuntary mental health patient. She was 18 years at the time of admission, and she was made involuntary because of an eating disorder. She had had a relationship with the services because of that, and that is the issue that comes out in the complaints, is that individuals will need to have ongoing relationships with the people who provide them the health services. So we do try to have a restorative justice approach in what we do. Unfortunately, at the time of admission, she had to be put into a secure adult mental health ward, whereas she normally had not been in. She'd been more in a youth ward and more of an open ward. And she put in a request for transfer, but there were no beds available, so she couldn't be transferred. Then she wanted to be put on a waiting list for transfer. That request seemed to go unnoticed. And then what started happening was she got concerned about her sexual safety, because one of the patients took a liking to her and was following her and trying to enter her room. So she became very frightened. So what we did is we popped this matter into conciliation, and actually we don't often do this, but this case required 2 conciliation meetings to actually get to the heart of the matter and to get some outcomes. And one of the outcomes was that she could specify for the future, because she was concerned that the treating team were ignoring her requests and not involving her in decision making, that in the future she could have a choice, a greater involvement in the choice, in the decision making around her future admissions, should that happen. And as happens with many of our cases, it actually was used for education and training purposes. So discharge planning, and that really is something I've had a lot of interest in over the years, because it either works well or it doesn't work well. And we see when it doesn't work well, which is unfortunate. And where it actually doesn't work very well is when patients from the regions have to come up for surgeries in the metropolitan area. And this particular case just symbolises those types of cases that we deal with. So a gentleman came to Perth and he was having spinal surgery, so very serious surgery. And a day before his expected discharge happened, his wife got a call to say he was ready for discharge. So she had to drop what she was doing. She had to drive to Perth. Meanwhile, there'd also been some discharge information provided to her on the phone. She was reasonably stressed by the whole thing. So when she arrived at the discharge lounge, she was concerned about her husband, but nonetheless, she took him home. There were pain issues post taking him home. he deteriorated, and the next day she had to take him to regional hospital and he had to be admitted. So during conciliation, it was acknowledged that maybe they could have kept the patient for the extra 24 hours as was originally planned, that the discharge process over the phone was not a good idea, and that there wasn't sufficient information provided about the medication that could be assisting him for his pain relief. And then as a result of that, there was also a service improvement, and that's again like this contributing to health services about discharge and pain relief and medication for situations like this where you're discharging to regional areas. In terms of medication, we can see where there's dispensing errors, and access to medication, denial of medication. Sometimes people shop around for medication. But in this particular case, it actually involves a gentleman who came in for emergency heart surgery. And it also relates to discharge, because at discharge, he was informed that he had to take the same medication for his heart that he was taking before the surgery, except the dosage was lower, but the frequency was higher. Anyway, the gentleman went home and took his old medication, which was at the higher amount, and so he was taking it more frequently as well. It ended up that he went back to hospital, and there were toxic levels of the medication in his system. So there was explanations provided, there was apologies for the distress caused, and then the service improvement was that there was an offer for future patients that they would destroy existing medications to avoid this happening, and where patients didn't want that to happen, for a risk to be provided to the individuals so they knew what was happening, and for that information to be put on the medical record that conversation had happened. Maternity does attract a number of complaints. In this particular case, it involved an induced labour. There was a umbilical cord issue, and there was a consequential cesarean section. The mother and father felt that the labour hadn't been handled very well. There was obviously a lot of emergency happening. There was a lot of, as much as these situations try to be calm, the clinicians are responding to the situation as they happen at the time. And they felt that the baby had been left at risk, and then they were concerned because they didn't get to see the baby for 15 hours post-delivery because of sort of resourcing in the hospital. So during conciliation, the hospital was very disappointed to hear that they hadn't received the level of care that was expected of the staff. There was recognition during this process that actually the medical records were not, could not really give a clear picture of what had happened. There was confusion amongst handover processes for treating teams. And so there was undertakings to, one, improve the record keeping, two, to make sure that handover of patients happens more smoothly and policies were updated. And again, this case was used for training purposes. I'll just talk about end-of-life care, because that actually, I'll tell you about one of our voluntary assisted dying investigations. So when you actually want to apply for voluntary assisted dying, you have to make what's called a first request. That starts the process. But up until that process, there can be some communication happening, and it's about getting into that process, because once you're in that process, it's highly regulated, it can be fast, and it can be smooth. In this particular investigation, there was a woman who was admitted to hospital. She had cancer. She was deteriorating, and she wanted to access voluntary assisted dying. Now, there was confusion from the clinician and the daughter of the family member as to who was actually requesting voluntary assisted dying, who was having this communication. And it was not clear. The clinician thought the mother was talking to the daughter, and the daughter thought that the mother was talking to the clinician. So there was a lot of confusion. Anyway, it delayed getting into the voluntary assisted dying first request process. And then what happened on the day of death, when the administrating practitioner came along to administer the substance that will cause the death, they have an obligation to make sure that somebody is of a decision-making capacity on that day. But because the mother had deteriorated so much, she was highly medicated, and so she'd lost decision-making capacity. And the administrating practitioner advised that she couldn't administer the substance. Now, the family were distraught, and they felt that this whole issue of the lack of moving on with this first request in the beginning of the process had delayed what had happened and affected what occurred on the day of death. And I could just imagine all the family were there. It would have been very stressful. So during that investigation, we found that there were issues wrong with the communication, with the record keeping, and this process of making sure that you get into this first request process. And we found that in not just this case, and they are the types of matters that we've reported to the Voluntary Assisted Dying Board. I do have to say that that patient, the mother, she did pass away of natural causes about 2 hours later on that day that the death was supposed to happen, but nonetheless, the family were distraught. Now, documentation and record keeping comes up in all these cases, so I'll move on for that, but I just want to tell you about carers, because I've seen more recognition of carers in the last 10 years in my role here. And in this particular case, again, unfortunately, it involved the death of an individual. The wife of a patient made her complaint to us in her capacity as a carer. She had asked the hospital, her husband was deteriorating, he was a palliative care patient, that if anything happened overnight, this particular night, for this condition changed, for her to be contacted. She turned up to the hospital and walked into the room where he was, and he wasn't there anymore, and he passed away, and nobody had told her. And so, you could just imagine how you would feel. And so the hospital acknowledged that the system had really broken down there, and they apologised. And they, again, used that case for education and training purposes. And communication, as I say, it covers all these particular cases. So the positive power of complaining. So this is how our feedback does change the health system, as I've just shown. In 2024-25, we had 584 redress actions facilitated. So redress can cover apologies, explanations, financial redress, and then 80 service improvements. And they are what benefits others into the future. So converting those individual experiences to provide redress. So as I say, there were 584 redress examples. Of those, there were 390 explanations, 93 apologies, 45 financial redress, 33 occasions where service was attained, 16 access to record, and 7 corrective treatment. And in the interest of time, I won't go through all of those now, but I'd just like to give you an example of an explanation. An explanation is a really powerful outcome, and often people want that more than they want apologies, and explanations can be underestimated. A really good example is a case where actually a service provider had not done anything. We didn't find there were any failings, any shortcomings, but it was a case where somebody's son had serious mental health issues, and he didn't respond well to the medication he was on. So he's popped onto a trial for a new medication, and he had really severe adverse outcomes. And so the family were concerned. In fact, he was so unwell he couldn't bring the complaint, so they brought it on his behalf. And through that process, there was an explanation provided about, one, the individual had consented to go on the trial. 2, the trial, the side effects were explained to him. And 3, that the medication was stopped as soon as the adverse outcomes occurred. So that was an example of where the family hadn't received that information, but through our process, they got that explanation. And then how powerful, yes, are our service improvements. You'll see there that a number of service improvements occurred as a result of our involvement. And you might think, well, okay, so what constitutes administrative process improvements? And sometimes it can be something small, but it has really big impact. And a good example is record keeping, where you wouldn't believe the number of times we actually find where vital signs are not recorded in records. And so there's most often in each year improvements in record keeping. But one particular case was actually simple as signage, new signage being placed on the door of a deceased person, because at the time of death, the family are given an opportunity before the person is moved to the mortuary to actually spend a bit of time with their loved one. And on this occasion, that was happening, and then the cleaners walked into the room because they'd heard that the person had died and it was time to clean the room for the next person. So again, you can just imagine the devastation of the family. And the simple thing of that was that a new sign was developed and it was just placed on the room not to enter because of the grieving family process. Clinical procedures, so sometimes vaccination errors do occur, and a quality assurance process, and also for dispensing errors for medication. And that quality assurance process normally involves the fact that you need to have 2 people to check dosages before vaccinations are given or medications are distributed. Improved communication and information sharing, well, I mean, that covers discharge situations. It covers where to contact people post-emergency over weekends. I don't know if any of you've ever left hospital and then it's a weekend and you're a bit concerned, where do I go? I've got cares over the weekend. Just having information available about what to do. And then staff education and training. So many of our complaints are used for staff education and training purposes, and that really helps develop the workforce for the future. And ultimately, this is what we're trying to achieve. This is what we want to see. We want to see compassionate care. This is how we all want to be treated when we enter the health system. So in conclusion, I'd like to say that complaints can be a positive way to influence change to improve health and mental health services. They can certainly generate safety and quality improvements and improve patient-centred care. And as I do say, from one complaint, there can be redress for individuals and system changes for many others who access health or mental health services. And just to finish on that, I'll give you an example of where the outcomes, the system improvements were very, very significant from the one complaint. And it actually involved, again, another deceased person. Sorry to be a morbid on a Friday afternoon, but this is the work we deal with day to day. The family came to us after their parent had been deceased and the English was not their first language. And they were concerned that the medication level for their parent had been increased and the consent had been given even from the individual, who knows how, because English was not her first language, and there was no family member present when that occurred, and the outcomes were not good. Their family member was very sedated. And so what happened there was, through the conciliation process, is it was recognised by this particular hospital that they needed to have interpreter services when family members were not present. And not only did they put that in place in their one hospital in Western Australia, they are a service that is Australia-wide. Not only did they put that change into their hospitals in Western Australia, they put it into all hospitals across Australia. And so that really does reinforce how the power of complaining actually can improve health and mental health services. So thank you.
That's great, Sarah. Thanks very much. Just go, that's right, so people can see where they go. HaDSCO, HaDSCO. If you just put that into your search engine, I'm sure you'll be able to find it and find out more about the organisation. So that's terrific. So you can probably stop sharing that and then we can have a quick chat. Just reminding people, go to Slido. There's already quite a few questions up on Slido, but you've got plenty of time to put some more up there. So SLIDO, so just go www.slido.com and our code is JCIPP. So a quick couple of questions. Some are, you've actually, people often ask these questions while you're speaking and then you answer the question. It's on their mind and you answer it, it's like you're a mind reader. So the first person asked the question, are you expecting an increased workload as NDIS participants are jettisoned from the national scheme? So This is from Alan Langford, who I know very well and is a good friend of Curtin University. So you talked about how people inside the NDIS system
Yep.
clearly have got a place to go to, and it's not you. But if there's moved, for example, to go to Thriving Kids,
Yep.
will complaints come through you or another organisation?
Yes, thank you for that question. And that has been on my mind in the last month. In fact, I recently was talking to child and adolescent mental health services about it for Perth Children's Hospital. And I also have conversations reasonably regularly with the Department of Communities because we need to establish where the Thriving Kids complaints will come. And I would imagine they're going to come to us. And so we just need to be ready for that. But whether or not they actually are provided by health providers or they'll go back to the traditional disability providers that have been providing NDIS services, I think is that sort of unanswered space for me at the moment. So we're certainly very alert to that movement happening.
And just as an aside, how do you, if you can already see coming down the track, this is going to happen, how does resourcing get decided upon for your organisation?
So we apply for resourcing in a similar way that all state government agencies do through the state government budget process. And so with the change in jurisdiction, we would look to apply for resources, or hopefully it would be well received. When the Code of Conduct came in 2023 for our unregistered space, we were successful in securing more resources for that.
Okay, great. Okay, next question is from someone I know very well. It's my wife, Barbara Goldflam. Hi, Barbie. What's the level of compliance on displaying information about your services? She's never noticed that information anywhere. So as you're walking in and so it says what services, which I guess also includes cost. Are there rules? What's the issue there?
So can you just unpack that a little bit for me?
About displaying information about your services. You know,
Okay.
and you had your 17 sort of, your code of conduct things
Yeah.
you should and shouldn't be doing.
Yes.
Is that part of it? You're sort of advertising your services and what you can say and what information you have to provide?
So yes, so we have information on our website. We have a specific section around the Code of Conduct. The Code of Conduct is actually prescribed in legislation, so it's available there. We have LinkedIn. We don't have a social media platform.
I think, sorry, you've misunderstood the question.
sorry.
What do providers, the people that health, what do they have to do in terms of their advertising of their services?
Okay, all right. So it's WA health policy for all the 5 public health service providers across Western Australia that on the bottom of their letters, when they've looked at a complaint, they have to put on there that if the individual remains dissatisfied, then come to us. So that does generate complaints. We also get referrals from the Minister's office. But, like a general practitioner, for example, might not necessarily know, even sometimes, that we exist. There are some people who don't know that we exist, which is a shame. And so they wouldn't know to inform people about us on their letters. But for WA health providers, the public health service providers, they need to inform us. And I have to say, somehow prisoners know to come to us too.
Yeah, but what about these unregistered, the health providers who are now enveloped in your system? So your doulas and your counsellors and your naturopaths. I mean, if they say you go and see them on a Thursday afternoon and pay whatever it is, and you're not happy, do they have to sort of say, by the way, if you're not happy with my services, here's where you go to?
In fact, I'm just getting out my paper copy of these slides. One of the clauses of the slide is, one of the clauses of the code is they've got to actually display information about us at their premises or on their website. Now, if we were to do an audit of that tomorrow, I don't think we'd find very high compliance. But we are doing as much as we can to promote and, through the associations, social work associations, counsellor associations, audiologists, to inform people that they need to tell people to come to us.
Okay, sure. Next question. What's the time frame for resolution of complaints? Okay,
so that can vary. And for some very simple matters, we're going to try and deal with them within a month. Some investigations will take longer. Some of those code matters will take 6 months or so. We have to wait for information to come through from the courts, as well in those cases. So they can take more than 6 months if they're very serious matters. Conciliations actually can take a bit of time because we have to be able to get the parties to the table. And sometimes the complainants pull out at a particular time because it's a bit traumatizing, and then clinicians are not available. We spend a lot of time trying to schedule those, which can make the time draw out as well, which is a bit unfortunate. But we don't have compulsion powers to bring people to the table for conciliation, whereas the Equal Opportunity Commissioner, the Information Commissioner, they have compulsion powers for their conciliations.
Right, thanks. Maybe this is something that can help you. Can you talk about the impact of generative AI, chat GPT, etc., on the amount and content of complaints and anything you are doing in response? So A, can it help you, or B, does it make your life a lot more complicated because people now generate complaints using chat GPT?
Yeah, there's two sides to that, and I just want to make sure I cover both off. One is the complainant. I like to call them individuals, but we do tend to use that term. And then one is benefits for us. So for complainants, yes, we are seeing individuals using AI to generate complaints. And the thing about providing a really accessible complaint service is you need to adapt your style for the literacy level that you receive the complaint. And so what you might receive a complaint that's generated by AI, and you're feeling like you're dealing with a reasonably educated person, and then you talk to the individual and you realize that they actually they're much more vulnerable, and their literacy level is much lower than the complaint they've submitted. The other thing is that AI will go away and find answers, will find medical conditions that people don't think they've got, etc. So it can actually be a hindrance as well. And we are seeing complaints that come in through AI. But on the other side to it, there are enormous potentials for us as an organisation to use it to triage complaints, to search complaints. We're sort of in a trial with WA Health at the moment about some of our staff are actually beginning to use AI because we actually get ICT support from WA Health, and we'll need to abide by the ethics of the WA government for AI, but there is enormous potential for us to have benefits as well.
Right, thanks.
I'd also just add that AI is being used by clinicians for diagnostics, for note-taking, etc. So there are all sorts of issues there around consent. And AHPRA actually has some really good information available for clinicians, practitioners about using AI. And people may not realise it, but if you use a medical device, it needs TGA approval, Therapeutic Goods Administration approval, and some AI enabled products actually need to be approved through the Therapeutic Goods Administration, and organisations are very ICT based and don't necessarily realise that they're caught up in this regulatory space when they introduce AI into Australia for medical reasons. So it's a really interesting area.
Right, yeah, someone else also was asking about how does AI impact complaints, which I think you've just answered. Thanks very much. Another question was, can you elaborate on the supports you have in place to support marginalised and disadvantaged complainants in culturally safe and appropriate ways, please?
Yeah. So we will in particular reach out to those advocacy services that can help, because we don't want to re-traumatise individuals through the process. So as I mentioned, the mental health advocacy service, in fact, that case I gave, the quality of clinical care one about the young lady who had anorexia, who was an involuntary patient. She was represented in that complaint by the mental health advocacy service. We will also use the Health Consumers Council they will bring the complaint to us, and we don't actually have the Australian Health Practitioner Regulation Agency has a notify support service. We haven't gone as far as that, like there's 26 of us. And so, there are models around of being able to provide support through processes. I know Work Health and Safety for work deaths also provide that support, a level of support. It certainly is an emerging area and an area that I would like to be able to assist more. But again, it's a resourcing constraint, but we will do whatever we can to support the marginalised person. We actually have in one of our triage indicators a vulnerable person, And so then that's one of our indicators that we a tick when we assess complaints, and then we'll adapt our style to assist that individual.
Well, which leads on to one question. I asked a question right at the very beginning just to make sure people knew they're in the right spot. But it links to what you just said then, because I wondered, do you have any connection to the HCCC, the Consumer Competition and Consumer Commission, or the Health Consumers Council? I mean, you just mentioned the Health Consumers
Yep.
Council. You might need to explain a little bit about who they are, because if you want to complain, who do you go to first? Do you go to you, or would you be better off going to the Health Consumers Council or the HCCC? In terms of, you mentioned sometimes some of the complaints might be about communication, but also communication will also be about false advertising, about overcharging. So when maybe it doesn't matter, maybe you get it and you send it on, but is there a dividing line as to where someone should go?
So there's two parts to that. Let me answer the second part first, and then I might ask you to ask me the first part again. In terms of the HCCC, so we have a strong relationship with Consumer Protection, the Department of Local Government Industry Regulation and Safety, because they get some matters that belong here and we get some matters that belong there. And a really good example I always use is when you go to buy new glasses, right? So the optometrist is covered by us, but the actual glass that you purchase is a consumer protection issue. And so if you're not happy, if you believe your prescription's wrong, that's definitely us. But if you believe that, if you don't like your glasses, that's a sort of commercial arrangement under Australian consumer law. So those matters would belong with consumer protection. So that's that relationship we have there. And then in terms of Health Consumers Council, so yes, so they're an advocacy group that are set up. They actually do advocacy on the spot to assist people when they are in hospital or, for medical practice. But they also will deal with matters of complaint and come and bring that complaint and represent them with us. So we have to be careful because we're not advocates. So we have to make sure we keep that boundary clear. But they really do provide an excellent service to assist individuals who are vulnerable to bring their complaints forward.
So would some of those 584 complaints or the 3,000 complaints you received have come from the Health Consumers Council as opposed to coming from an individual who's gone through the Health Consumers Council? Do you have to receive a complaint from an individual, or can you receive a complaint from the Consumers Council on their behalf?
Yes, if on their behalf, the individual just needs to sign an authorisation for us to deal with it. Just like if you had a friend who you wanted to help you with a complaint, you would have to authorise that person to do it. Yeah, right. But the person can't. You can't be paying the person, so a lawyer cannot represent somebody in a complaint to our office.
Right. Okay. So if you're looking for, you did mention financial redress there.
Yes.
But I assume often in medical cases and of malpractice or negligence, they go through the courts and there's big damages paid. So you're not talking that sort of thing with you? No,
we're not. But a really good case where I think the biggest financial, one of the biggest ones I've known here was a hospital that agreed to pay the funeral costs as a goodwill gesture for somebody who'd passed away because there'd been shortcomings in the process. Obviously, the person had long and truly been buried, etc. But they sort of reimbursed the family for the funeral costs. But that's a goodwill gesture. Or, there might be a fee refund where things have been charged twice. Yeah. But anything to do with compensation needs to be in the courts.
Sure. Okay, two more questions. And W says that you mentioned not seeing the same psychiatrist regularly. With current staff shortages, how do you assist people, and can you take action at the policy level? So, it might be the provider might say, well, what can I do? There's massive turnover, staff shortages. That's the best we can do.
Yeah, I know. It's very true. And, it's trying to restore that relationship the individual's got with their new psychiatrist. I think the real classic example for me is pediatrics. So, really unwell children are going to have a long relationship with maybe Perth Children's Hospital. And they come to us saying, well, we just don't like the decisions that are being made about our child. We want a new pediatrician appointed, but there's they're very few, like it's a specialized area and, resourcings are low. So what we try to do is get involved to restore the relationship, because that relationship might have to be ongoing for some time. And it's the same in psychiatry. And look, and sometimes maybe it's a good thing that psychiatrists are changed, because individuals can get to rely a bit too much on their practitioner as well. Yeah.
And in terms of broader policy issues, I mean,
Oh, yes.
think about, but before you answer, I mean, the last question we have here was, do you maintain records or metrics on the complainants you assist, and demographics, frequency, in an effort to identify potential patterns in health? So again, how do you translate, and this has always been an issue for ombudsmen as well, how do you translate from the individual, which of course is incredibly important, to a broader sort of policy related impact?
Yeah, and you see, that's the thing, we're not aligned. As much as I report to a minister, the minister's only got certain control. Like, she can't actually tell me how to run an investigation. I have a female minister at the moment, the Honourable Meredith Hammett, but she can refer a matter to me. Likewise, I can't push for policy changes. You can get those service level improvement changes on a case by case basis. But if people are wanting data from us for policy changes, they can come to us. Like maybe corrective services might want to know particular issues that are themes in complaints. So we can provide that data, but we're not actually the drivers of policy changes, except for where there are legislative changes that we have to implement, like implementing the Code of Conduct.
Or you can make submissions where legislative changes are being proposed about, in your experience. You can say, in our experience over the last 5 years, X percentage of people of a certain demographic providing have experienced problems, and hence you might need to look at this. You can do that sort of thing.
We can. Like, for example, I mentioned about the submission we made on voluntary assisted dying, because of the themes that we have seen emerging in voluntary assisted dying complaints, this whole sort of nebulous organic part of the process where people think they're making requests to get into the process, but they're not actually formally making those requests, or they're going unheard. So we certainly have provided that as a theme arising from complaints in the submission on the voluntary assisted dying process.
Cool, thanks. Well, look, Sarah, it's five past. No, it's almost 10 past 5. I think we've probably exhausted you. It's on Friday afternoon. You've done a great job for us, and thank you very much also to our people watching, all those interesting questions. It was very helpful. We will be putting this up on our website as usual, and so if you've got colleagues or friends who couldn't watch tonight, but you reckon they would be they'd benefit from knowing more about HaDSCO, please direct them to our website in a few days' time, and I think that'll be really useful. So, Sarah, great work you do. I must admit, I didn't know much about HaDSCO. I vaguely heard of it, but I didn't know too much about it. I know a bit more about the Ombudsman, but I didn't really know about our inverted commas health Ombudsman. And it's great to have somebody with such knowledge and experience as you on the case, and all power to you, and good luck in the future. Thanks very much.
Thank you. Thank you so much. Good night, everybody.
Thanks, everybody. And before you go for the weekend, just letting you know, next week we do have a talk. Peter Newman, many of you know of. Peter's going to be talking about the Gulf oil crisis and can we accelerate the transition from oil. So that'll be a very interesting topic. So that's next Friday afternoon, 4 o'clock. Professor Peter Newman, again online. And we'll see you there. And in the meantime, have a great weekend, and see you at a future Curtain Corner. Thanks again, Sarah. Good night, everybody.
Thank you.